is not yet something that we're going to do to everybody. On the flip side, there's obviously a real biologic basis. With just 8 genes, we could tell 2 groups of people who are 3 times higher or lower risk of spreading. There's a scientific potential benefit. Can we scientifically study these genes? Can we refine the understanding? For example, maybe it's really good for one kind of melanoma, but some subtypes of melanoma, we could already say, oh, you know what, those aren't quite the right genes. Let's take these genes and use them in this patient and come up with an even better signature for the other kind of patients. That's just one hypothetical possibility. So obviously, anytime we got, something that we can say scientifically, there's something going on here, then we can learn, drill deeper, understand it even better. Again, the large number of cases, it helps us understand practice patterns, recognize, are we doing the right thing, and start a conversation with our patients. What's the right number for you? I have patients who say 6%, 5%, 7%. What are you talking about? If there's even a 1% chance, I want to know. Now I say to them, actually, you don't. What do you mean I don't? 1% chance, the side effects, the chance of a problem from the surgery, the chance that we'll miss the right node, just because that happens every 1 or 2%, are higher. All the bad things are higher than any of the good things. So we're okay taking our time and not doing the surgery for 1%. But the difference between 5 and 7%, to me, that might be enough. To somebody else, they may say, 7%, I'll take a chance. Equally important, as time has gone along since sentinel node biopsy became popular 30 years ago, what we do with that sentinel node test result has changed, right? Which patients have further surgery? Almost none of them. It used to be anybody who had a positive node had all their nodes taken out. Now we don't do that. Then it used to be, well, if the node comes back despite the sentinel node biopsy, then we'll take all the nodes out. Now with neoadjuvant therapy, sometimes we don't even take all the nodes out, even after a reoccurrence, because we use systemic treatment. Some people get adjuvant therapy, some people don't. The focus probably can now go beyond just, should I do the test or not? And really begin to ask, if I do the test, if I know it's a 7% risk or a 20% risk of a positive node, how does the node test, how does the sentinel node status itself change what we do? And therefore, when do we use it? When do we not? If it doesn't help us, do we need it at all? We still believe that sentinel node biopsy is extremely valuable. Again, even in somebody who's young and healthy and has only a 7% risk. But a lot of continuing discussion. When do we need this? What do we do about it? If we aren't going to change what we do for the patient, does it matter? Does taking the sentinel node out by itself do enough for the patient? I think it does. Others can argue differently. This kind of data, these kind of numbers, I think, I keep coming back to this, it changes the conversations that we can have. It allows us to begin to really dissect out what are we getting for our money, whether it's we're paying for the sentinel node or we're paying for the test and only doing the sentinel node if the test tells us they're high risk. What are we getting? These are really important and valuable conversations to have, and you can't have them if you don't have really solid data to back it up.